Great. Good morning, everybody. And first of all, I just want to thank you. Thanks to the National Academies, Dr. Kaiser, and everybody here. We're so excited about this event. For those of you that don't know me, my prior position was the position that Dr. Kirsch is serving in, and so I was very involved with access and scheduling in VA, and so feel like this is a great opportunity to give you an overview of VA as well as access. Next slide, please. It doesn't seem to be working. It is working. Sorry. There we go. So this is a time of dramatic change in VA. Many people, including our executive in charge, Dr. Stone, who's sorry he couldn't be here today, say that it's as dramatic change as under the era of Dr. Ken Kaiser. Some of you may have heard of him. And we are seeing more and more veterans enrolling with us. At last count, we were over 9.1 million. Of those, about 6.34 million are coming to us for care right now. That number continues to grow, and it's predicted that with the implementation of the Mission Act, which I will talk about momentarily, that the number of enrolled will go up a little bit, but more importantly, those that are enrolled not seeing us will come to rely on VA for more and more of their health care. We also are seeing and completing more appointments every year. Since the time of the access crisis in 2014, we are completing 3.4 million more appointments per year. Last year, about 58.2 million. This year, we're already up almost 1.5 million from the prior year, with a big focus on improving productivity and access in a variety of modalities. As you can see, we have 170, it's actually 172 medical centers at last count, and 1,074 outpatient clinics across the country. We're very busy. We have a hub and spoke model, if you will, with one main healthcare system and then one or more outlying clinics, many of which are in rural areas. We're in the process of evaluating where all our clinics are located right now to see if they're really in the correct place. Okay, sorry, I'm not doing well, but now we'll do better. Let's do one more time. Okay, so the Secretary Wilkie, has 4 priorities for us. First and foremost is customer service, and that's certainly the traditional customer service for those that we serve. It's recognized how important that when people choose their health care, and we want veterans to choose VA for their health care, that customer service is such an important phenomenon. This is also customer service for each other that are working at VA. Concept is if we have engaged, happy employees that treat each other well, in turn we will treat our customers well. Implementing the Mission Act, which is so huge, biggest piece of legislation we've seen in a long time in VA also. Right now we're focusing on the access standards. I have a slide on that, but there's so much more to it. Expanding our caregiver program, in helping us with recruitment and retention, creating residency slots, offering education debt reduction for residents, creating scholarships for medical students, and on and on. Telehealth, being legally able to do telehealth across state lines, all really important things for improving access. Next one is the electronic health record. We'll talk more about that momentarily. And then related to the electronic health record, transforming our business systems. So our financial management system, our supply chain system, on and on, all interrelated with our electronic health record system. The quote in VA is one VA is one VA, and we want more to be that all VAs are like all VAs. So you go in and you get the same treatment for the most part, get the same management, same supplies at each VA. So VHA priorities, really aligned with the Secretary's priorities, restoring trust in the veterans and the American public. We've been under attack since 2014, again with the access crisis. Also restoring trust of our leadership because of what's gone on in recent years. A lot of our leadership are afraid to take chances because of a large number of leadership removals. Leadership are afraid to go to higher level positions, and so as a part of that, we're implementing what's called a high reliability organization, which I'm sure many of you are familiar with. This is something we did well in the past in the VA in the 90s and after the turn of the century. It's really implementing a patient safety healthcare system, and we have that in VA, but we've lost our way a bit in recent years, again with the access crisis, and so focusing again on when an error happens, it is caught early, and hopefully we're preventing harm from occurring. And then for leadership, it's a fair and just culture. It's not, when something goes wrong, it's not who's to blame, but what was the breakdown in our systems. Creating a learning organization so that each VA can learn what went right and what went wrong at different VAs. We don't do a great job at sharing across our enterprise. And then finally modernizing a whole variety of things, which I mentioned many of them. Our structure in VA Central Office, our governance, and a lot of our different systems. Keep going the wrong way. Mission Act access standards. So if you read the papers, they're going to tell you that the goal of the Mission Act is to privatize VA. We do not believe that. We believe that veterans do want to have more choice. We've heard that from veterans, and so we're giving them more choice. We're opening the aperture where they have that ability to make a choice. But we also hear from veterans that they want to continue to choose VA, but we have to continue to improve and strengthen what services we provide, our access, our timeliness. And so we see this as an opportunity to grow and strengthen our access. And a big part of it, or related to it, is our scheduling system, as you will hear. If you look at all the criteria, there's actually 6 different criteria on the access standards, and you don't really have to understand all of them. The second main bullet is a big part of it. If under the Choice Act you were already eligible because you lived greater than 40 miles away, you would still be eligible. If you don't have a full operational VA hospital in your state, you're eligible. Best medical interest, which is where between the patient and the provider, that there's a discussion that if you don't meet any of the criteria, but it's really in your best medical interest, you've had a stroke, and it's really hard for you to go anywhere but in your town for your physical therapy, you and your provider can discuss that and make that decision. And then there are criteria listed under the first bullet for primary care and mental health. If the wait time is over 20 days, if the drive times are under 30 minutes, for primary care and mental health, and then for specialty care, under 28 days or drive times under 60 minutes. These are based on standards in DOD or standards in the community. And I would ask everybody to please make sure you mute your mics if you're listening in, please. Thank you. So these are where the veteran is offered the opportunity to go out, but they're just offered. It's up to them to decide. And again, we want them to continue to choose VA. So the electronic health record, we are very excited about this. We go live in the Pacific Northwest in March of the coming year in Seattle and Spokane. And we will then be rolling it out over the ensuing 10 years. We are working closely with DOD to learn from their experiences. What worked well and what didn't work well. We know that they had a bunch of bumps along the way, and we really appreciate their partnership as we are moving forward with this. This is going to be just so important for us as an organization, not just as a record-keeping system, not just as a scheduling system, but it's also going to help us with becoming a high-reliability organization with change management. And right now we have 18 clinical councils that are meeting on a recurring basis to help define the way forward for us with this change management. And then finally, our Cerner standalone system. And we did a pilot, an epic pilot at the Columbus VA. And we wanted to see how such a system, a scheduling system, would help us And we found major improvements which helped us to make a business decision, which I will describe for you in a moment, to roll out, actually I'll just describe it for you, to roll out for those sites waiting the longest for the full rollout of the Cerner system, those that are waiting 6 years, 7 years, 8 years, 9 years, 10 years, that we will do a scheduling standalone system. We will not roll it out until after we go live in the Pacific Northwest. We want all of our energies to be focused on that. We will start to roll it out about 6 months after that. And so what did we learn at Columbus that helped convince us this is the right way to go? Well, first and foremost, we have an archaic scheduling system. If some of you have seen it, it promotes errors. You know, you hear in the news about how VA was purposely committing errors, and certainly I won't dispel that that didn't happen at some locations. That there was allegations of malfeasance going on at certain locations. But from my experience working with schedulers and working with staff, the bigger issue is that this system promotes errors, and that's why we have to change it. And lo and behold, when we implemented this system in Columbus, Ohio, number one, the time to complete an appointment decreased by about 50%, which was pretty impressive to us. Number two, the scheduling error rate, which currently in our country, there's some kind of an error that occurs approximately 10% of the time, and that's actually an improvement over what it used to be. It used to be much higher. That in Columbus, Ohio, the error rate essentially went down to about 0%, pretty close, which is pretty compelling in itself. And then our provider productivity went up an average of 8% just by switching from our archaic scheduling system to this one. And if you're wondering why that is, it's because in our current system we have what are called scheduling grids. Because our system is not sophisticated, for a given mental health clinic we could have 10 scheduling grids for different veterans going for telehealth, or veterans going for post-traumatic stress disorder, is going for a whole variety of different things. We set up clinics so we know what the veteran's coming for. That's not very efficient. In our new system, as will be in our new Cerner system, we now have one grid. And so that's why the poor scheduler who had to look at these 10 different grids to see where there's an opening now can see very easily at Columbus, Ohio, and soon where we roll out the Cerner system and the standalone system, they will be able to see where our openings are and just easily be able to put them in. And so without much effort, our productivity increased. This made a compelling argument of why it made sense to start to roll out the standalone system at those locations that are waiting the longest. It looks like we will even save money for the American taxpayer in the long run by rolling this out early with the productivity increase, and it also help with making the lives of our schedulers much better. So with that, I will finish up and say, you know, we again, if you can't tell, we have a lot going on. We're so happy to get your insight and your advice on this, and I look forward to seeing the final report when it comes out. Thank you.
So if there are any questions for Dr. Lieberman, now would be the time to pose them, either from here in the room. And if you could, again, introduce yourself and then state your question.
Doesn't sound like it is, or it should sound like it.
Okay, great. Steve, thanks so much for that overview. So I'm Lisa Lehman. I'm the Chief Medical Officer in VA New England Healthcare System. Okay. Just a quick question on the pilot that was done in Columbus. It says that was supported by Epic. I assume that's the EHR company, Epic. And what's the relationship between that and what we're going to have rolling out in terms of Cerner? Do we have confidence that the Cerner scheduling system that we're hoping to implement will mirror what was done in that pilot in Epic and give us the same efficiencies that you described?
So we believe that there is a strong relationship, that they are similar types of systems, and that we should have similar types of improvements, absolutely. So that's why we made that decision based upon that opinion, yes. Thank you, Lisa. Thank you. Anybody else?
phone?
Thank you very much.